Hi, this is Dr. Lori Gardner, and I will be lecturing on COVID-19, acute and chronic. The objectives for this lecture are to discuss the pathophysiology of SARS-CoV-2, describe the goals of treatment for COVID-19, and to discuss the rational drug selection for preventative, outpatient, and inpatient pharmacology. So let's just talk about COVID-19. And why are we discussing COVID-19 when that was a pandemic that happened in 2020? Well, coronavirus is here, guys. It's still here, right? Believe it or not, coronavirus was first identified in the mid-1960s and received their name because of the crown-like spikes that are present across the surface of the viral particle. There are four main subgroups of coronaviruses that commonly affect humans: alpha, beta, gamma, and delta coronaviruses. Humans frequently become infected with the following coronaviruses: 229E, NL63, OC43, and HKU1. These typically cause symptoms of the common cold. However, there are 7 coronaviruses that can affect humans and include 3 more widely known, which is the MERS-CoV, SARS-CoV, and SARS-CoV-2, the specific virus responsible for the most recent pandemic is the SARS-CoV-2. In this lecture, we're going to discuss pathophysiology, goals of treatment, rational drug selection, preventive pharmacology, outpatient pharmacology, inpatient pharmacology, and patient education and follow-up. Viruses are all relatively the same in the sense that they're either pieces of RNA or DNA that are enclosed in a protective coat. They can survive outside of a host cell, and they've evolved with the ability and need to reproduce inside the host cell they infect. During the process of replication in a host cell, the host cell is usually destroyed or at least damaged beyond homeostatic function. Additionally, viral pathogens are obligatory microbes. That is, transmission is propagated from infected cells to healthy cells. There's 4 steps that every viral pathogen, including SARS-CoV-2, must overcome to be successful in creating a source of infection. The virus must access and infect a target cell in a host. The virus must reproduce itself in the host. It must evade the host's immunity defenses, and it must be transmitted into another host cell. Consider that viruses must evolve and adapt to continue thriving, and in general, viruses like to infect larger organ systems. With a large organ system, it's possible to infect and kill or damage larger number of cells without causing very serious harm to the host. Some of the extrapulmonary effects of COVID can be found on table 34.3. So when we talk about extrapulmonary effects, what do we mean? Some of the effects on the heart include cardiomyopathy, myocarditis, and arrhythmias. On the hematological system, they may have deep vein thrombosis, pulmonary embolus, or catheter-related thrombosis. They may have headaches. They may have dizziness, encephalopathy. Some may have Guillain-Barré, myalgias. It can cause hyperglycemia and DKA. Some other effects include nausea, vomiting, diarrhea, abdominal pain, and anorexia. There's a whole list of extrapulmonary effects on table 34.3. So, what are the steps for a viral pathogen to infect the host? Again, attachment to the target cell, penetration of the host cell, replication of viral RNA or DNA as well as viral proteins and mRNA, upcoding and release of viral RNA or DNA from the viral capsid or host enzymes, assembly or the formation of new virions, and release of viral proteins either by lysis of the host cell or by cell budding. SARS-CoV-2 has a virion spike protein attaches to the angiotensin converting enzyme 2 or ACE2 receptor. There's direct cytotoxic effect of the virus on host cells, and it causes dysregulation of renin-angiotensin aldosterone system, or the RAAS, by inhibiting downregulation of angiotensin 1 to angiotensin 1 through 9 and angiotensin 2 to angiotensin 1 through 7. Host vascular system is in a high state of inflammation, so there's vasoconstriction, tissue injury and remodeling, and vascular permeability. The endothelial cell damage and thromboinflammation leads to apoptosis of the cell in vascular beds, secondary to the prolonged inflammation. Leads to decrease in fibrinolysis and increased thrombin production. It activates complement cascade pathways leading to microvascular dysfunction and thrombi deposition. The goals of treatment are multifactorial and include preventing unnecessary morbidity and mortality and reducing the burden of disease in patients. They also include protecting the general public and further spread of this highly contagious virus. So we want to prevent morbidity and mortality and reduce the burden of disease by preventing the transmission of infection from person to person. A strong emphasis on treatment should center on preventing further transmission of infection, reducing the overwhelming burden on a taxed healthcare system, and exercising judicious stewardship over limited resources. The global pandemic of SARS-CoV-2 has challenged the way healthcare professionals deliver care and forced health systems to rethink how the delivery of care and utilization of finite resources are delivered. General principles guiding treatment in the outpatient setting include rendering a timely assessment for the eligibility and ineligibility of treatment, evaluation of the patient, whether in person or via telehealth, and rendering treatment based on patient examination in the outpatient setting or arranging for a higher level evaluation and care in the inpatient setting. Assess the acuity of the illness. Advanced age is a significant risk factor of poor outcomes, and determine whether inpatient or outpatient treatment is most appropriate. Drug selection for the treatment of SARS-CoV-2 depends on whether the patient is stable enough for outpatient treatment or whether they require a higher level of care in the inpatient setting. But first, focus on preventative measures, like encouraging your patients to get vaccinated. Vaccination is effective in decreasing morbidity and mortality. In the fall of 2023, the FDA updated the emergency use of an updated COVID-19 vaccine formulation that includes a monovalent component that corresponds to the Omicron variant XBB 1.5. The vaccines for 2023-2024 are manufactured by Moderna and Pfizer. These vaccines are authorized for anyone over the age of 6 months, and with additional doses authorized depending on age and immune status. Prescribers must be cognizant of the fact that SARS-CoV-2 mutates and changes. Pharmacology recommendations also evolve as previous medication recommendations are no longer as efficient as they were in the treatment of previous variants. So treatment and best practices are still evolving. Drug selection depends on patient stability and how the SARS-CoV-2 has mutated and changing. So there's constant changes in the pharmacological recommendations. In the outpatient setting, there are a limited number of treatment options available for treatment alongside supportive and adjunctive pharmacology. The FDA has approved the use of nirmatrelvir and Paxlovid for the treatment of patients with mild to moderate COVID-19 who are at risk for progression to severe disease. You guys have probably heard a whole bunch of commercials for Paxlovid. Remember, that's from mild to moderate. So if you're treating outpatient, you want to reduce hospitalizations and death, starting within 5 days of symptom onset. The dose is dependent on their renal function. You want to avoid both of these in severe renal disease and avoid use with drugs that are strong CYPA inducers like rifampin, dilantin, and carbamazepine. Prescribe these as monotherapy and not combined with other treatment modalities. The medication should be started as soon as possible after the onset of symptoms, but no later than 5 days after they've had symptoms. So, when we talk about renal function, remember, the dosing is dependent on renal function and is not indicated for patients with severe renal disease. And what's severe renal disease? If they have an estimated GFR of less than 30, treatment's not indicated for them. Normal renal function is 60 or higher. So, nirmatrelvir is dosed at 300 milligrams. Paxlovid is 100 milligrams twice a day. The dose pack contains 2 150 milligram nirmatrelvir tablets and 100 milligram Paxlovid. Inpatient pharmacology includes remdesivir, molnupiravir, and convalescent plasma. The remdesivir is preferred and it requires an IV infusion over 3 days. That should begin within 7 days of symptom onset, may cause nausea, hypotension, and bradycardia. Molnupiravir used only when there is no other available option. Avoid this in pregnancy, may cause diarrhea, nausea, dizziness, and urticaria. And then the convalescent plasma is an IV infusion. That's probably more beneficial within the first 8 days of symptoms. It is not first-line treatment, and it's not widely available. There are some other medications that can be used, like Janus kinase inhibitor. That's used as an immune modulator. They use that for progressive respiratory failure requiring high flow oxygen or mechanical ventilation. It's used very cautiously in those who are severely immunocompromised, and you should avoid it if they're receiving interleukin 6 pathway inhibitors. And of course, be very cautious in renal dysfunction. The interleukin 6 improves outcomes by blocking the inflammatory pathways. And here on this slide, you can read the dosing for the single IV infusion. Now, if they're over 75, have severe pneumonia, if they were a current or previous smoker, if they have organ failure, you check the score, then you want to be very, very cautious and avoid giving it to these patients. When you're educating your patient, make sure you're giving them current information on infection control measures from the CDC. And there's a different way to treat each patient based on if they're exposed, if they've been vaccinated, if they have not been vaccinated. So the date of exposure for SARS-CoV-2 is considered day 0, and day 1 is the first full day after the patient's last contact with the source of infection. Patients who are exposed to SARS-CoV-2 and are not up to date on their vaccines should receive the following information. So if they were exposed and not vaccinated, they should quarantine for 5 days, monitor symptoms for 10 days, and wear a mask, and get a COVID-19 test at day 5 after exposure. They should wear a well-fitting mask, and they should also avoid going places that they cannot wear a mask. They should get tested even if they're asymptomatic at least 5 days after they've had contact with someone with COVID-19. And if they develop symptoms, they should get tested and remain at home until they have results. Individuals who are exposed to COVID and they're current on their vaccines, they should monitor for symptoms for 10 days, wear a mask for 10 days if they're around others, and get a COVID-19 test 5 days after exposure. Individuals who test positive for SARS-CoV-2, regardless of their vaccine status, should quarantine for 5 days, 10 if they have an exaggerated illness or they're immunocompromised, and wear a mask and avoid travel for 10 days from their positive test. Teach your patient when to follow up and when to go to the emergency room. You should ensure rapid and early COVID-19 testing, as well as assess the acuity of the illness through a thorough history and physical exam. Vaccination is the hallmark for COVID-19 primary prevention, and the patient must be assessed for appropriateness of inpatient versus outpatient treatment. So when should they go to the emergency room? If they have worsening dyspnea, if they have chest pain and pressure, if they have dizziness or confusion, uncontrolled fever, or cessation of eating and drinking leading to dehydration. Now, let's do a knowledge check. Which of the following is used to treat mild to moderate COVID-19 in the outpatient setting? You should have learned that in this lecture. True or false? Patients who were exposed to SARS-CoV-2 and are not current on their vaccine should do what? I'm sorry, that's not true or false. That's a question. What should patients who are exposed to SARS-CoV-2 and are not current on their vaccines do? When you're teaching your patient, what are you going to tell this patient? Okay, any questions? If so, just contact me.